Hello people, in this video we want to look at allopurinol. So now where exactly are we? Do you know where we are? Okay, we will take you back and show you a recap. We are in anti-gout drugs pharmacology, correct? Do you know what gout is? Hyperurecemia. So here what happens, these uric acid crystals, they go and deposit in the joints and even in the kidney. They also are going to deposit in subcutaneous tissue. That time it is called as tophi. Correct? So this is gout. Gouty arthritis means when it deposits in the joints like this. This is gouty arthritis. The causes of this hyperuricemia are something like purine breakdown, right? When purine breakdown happens, xanthine is released and that will convert into uric acid. Uric acid has to be removed in urine. Right. So what happens when excess breakdown is there, excess uric acid gets produced, and if there is some problem in the kidney where it is not able to remove this much uric acid, when the excretion is low, then uric acid will become more, and here you can see how it will go and deposit in all these joints, etc. Another cause for this hyperuricemia can be leukemia and some drugs that people are taking like thiazides, furosemide, which are diuretics, right? They act on the kidney. So all these causes can increase hyperuricemia. Now, you know, like if it is going and deposit in the joint, then it's called as gouty arthritis. Now coming to the drugs which are used to treat gout, remember acute gouty arthritis, you should give only this anti-inflammatory. Like NSAIDs are what non-steroidal anti-inflammatory drugs like diclofenac, indomethacin, so many other drugs that you can give for acute gouty arthritis. NSAIDs are the first choice. Then if they are not responding to NSAIDs, you can give colchicine. Colchicine, what it will do, it is acting only against gouty inflammation. So it will suppress only gouty inflammation. And you can give steroids. Only after all this comes to control, right? Only after this acute episode comes to control, only then you should give these drugs. Because these drugs are going to work on the uric acid levels, and if you give them during acute episode, then they can precipitate uric acid levels. I really don't know how, but they are saying that during gouty episode, arthritis, acute episode, don't give these drugs. Don't try to solve the problem, okay? Don't try to solve the uric acid problem. First, try to just reduce the inflammation. Then we will see, they're saying, okay? So this is how anti-gout drugs work. Now, when it comes to chronic gout, that is where we are currently, we want to cover allopurinol, correct? Allopurinol is the first choice of drug. It is the first choice. That should be written here. This is the first choice for chronic gout. First choice for chronic gout is allopurinol. Remember, the first choice for acute gout is NSAID. Okay. So allopurinol is what it inhibits the synthesis of this uric acid. So it is a very good drug. It is very well tolerated, etc. So synthesis inhibitor allopurinol is the first choice. Then you have this probenecid, which is a uricose-uric drug. Uricose-uric means actually they just increase the excretion. Okay, they increase excretion of uric acid. That's all. I'm not sure uricose-uric means what. Is there in some hidden meaning in that uricose-uric? I don't know. But it just says that it increases in excretion of uric acid. Anyways, our focus in this video is allopurinol. In the previous videos, we have covered NSAIDs, colchicine, corticosteroids, probenecid, everything we have covered. Now we are moving on to allopurinol. Okay. Just see what and all we have covered. Acute gouty arthritis, NSAIDs, indomethacin, diclofenac, pyroxicam, etoricoxib, naproxen, everything we discussed. So non-steroidal anti-inflammatory drugs, they are COX inhibitors, right? They also stop the migration of leukocytes to the inflamed joint, right? So that is how NSAIDs work. Then we saw colchicine. Colchicine is the fastest acting drug, okay? And it is how it works, colchicine. It is suppressing only gouty inflammation. Only for gouty inflammation you can give. It is going to bind to fibrillar protein, that is tubulin, and inhibit granulocyte migration. This is the main action. You should know this. Okay. This colchicine is excreted in bile. So this is colchicine. Okay. Then we saw some small action of steroids. So basically they are given by intra-articular injection. This is the nice thing here. This is the only unique thing that you have learnt here. Intra-articular injection of corticosteroids for treating acute gouty arthritis. This is a local route of drug administration directly into the joint. They will give the injection. Now coming to chronic gout, this is where we are. We have already covered probenecid in the previous video. Basically, probenecid, what it does, it makes sure that it is blocking this organic acid transport. So what it will do, as it blocks this, uric acid cannot be reabsorbed, right? So it increases the excretion of uric acid. Okay, so that's all. Then it increases the level of penicillin and other drugs. Okay, it increases the level of rifampicin, penicillin, everything. It increases the drug levels of other drugs. Okay, this is the main thing. This much if you remember for now, it's enough. Now we are coming to allopurinol. This was the whole intention of this video, allopurinol. Now allopurinol actually is a hypoxanthine analog. So you know hypoxanthine became xanthine, right? That is what we saw. Hold on. So just look at this diagram. See, purines are broken down. Okay, purines are broken down. You get hypoxanthine. Now hypoxanthine becomes xanthine. Then xanthine with xanthine oxidase, it becomes uric acid. Okay. So they are saying this allopurinol is a hypoxanthine analog. So if it is a hypoxanthine analog, what it will do, let's see that. It is a hypoxanthine analog. It is very small for you to see. It's a hypoxanthine analog. It competitively inhibits xanthine oxidase. So it will not allow the xanthine to bind to xanthine oxidase, right? It is going to competitively inhibit this thing. So xanthine will not be able to go and bind to xanthine oxidase, because this, who will come and bind here? Allopurinol. So allopurinol, it's already written here, allopurinol inhibits xanthine oxidase. It's a competitive inhibitor of xanthine oxidase. Yes, it's written here, allopurinol inhibits xanthine oxidase. So it is suicide inhibition. That means it will give up itself. It is a suicide inhibition. Allopurinol suicide inhibition. Okay. Hold on. So here we saw that it is a competitive inhibitor of xanthine oxidase. It's a suicide inhibitor. That also, if you want, you can remember. Suicide inhibitor. So it has short action of 2 hours. But the thing is, this allopurinol, it becomes another metabolite, which is alloxanthine. So there are 2 things here. Allopurinol becomes alloxanthine. So when it becomes alloxanthine, this one has long acting, it has long action, and it's a non-competitive inhibitor of xanthine oxidase. So basically, it has both the ways. It is a competitive inhibitor also, then it becomes a non-competitive inhibitor also, but whatever it will inhibit xanthine oxidase, that's all we want, right? Now this drug will, what and all it will do? Now if you look at this diagram, obviously you will understand. It will inhibit the xanthine oxidase, right? Competitively, non-competitively, whatever. Allopurinol competitively it will inhibit. Allopurinol competitively it will inhibit. Then you have alloxanthine. Alloxanthine will non-competitively inhibit. So this one, the allopurinol itself is a competitive inhibitor. It's a very strong thing. It's a competitive inhibitor. Then alloxanthine is going to be non-competitive inhibitor. Whatever they do, finally they will inhibit the xanthine oxidase. So no uric acid. Uric acid levels will come down, but xanthine and hypoxanthine levels will go up. That much you understood, right? So this drug will reduce uric acid levels in the plasma. In the plasma, this obviously that was the whole point of giving allopurinol to the patient. Wake up. If you are sleeping, please wake up. Basically, the whole point of giving allopurinol is to reduce the uric acid synthesis, right? So obviously, the drug will reduce the uric acid level in plasma, but the hypoxanthine and xanthine levels will increase. Hypoxanthine and xanthine, these are more soluble in, so hence anyways they are easily removed with the urine. So that is great. So it's a win-win situation. Everything is a win-win situation. So basically hypoxanthine will increase, xanthine will increase, uric acid will reduce. These anyways are easily excreted in urine. So whole problem solved. And when this level slightly increases in the blood also, what will happen? There will be a negative feedback, and purine breakdown also will be reduced. So it's a win-win-win-win situation with allopurinol. Okay. Then So this hypoxanthine and xanthine, we said they are more soluble and they are easily removed in the urine, correct? So there is no precipitation of these also in the urine. Now let us move on. Wake up, take a break, take a deep breath. Okay. So now let us continue. Due to increased hypoxanthine, negative feedback, purine breakdown also is reduced. This also we already told you. Oral allopurinol they are giving. Look at this. Allopurinol is given orally. Look at this guy. He's taking allopurinol orally with water. Lot of water they should take. Just like probenecid. Lot of water should be taken with these drugs. Okay. Then what happens? Allopurinol is taken orally. It is not bound to plasma protein. This is a very interesting thing. I never saw anything like this so far. Maybe a lot of drugs are there. First time I am seeing this. Allopurinol is not bound to plasma protein. And it is a suicide inhibitor. It inhibits its own metabolism. It's a suicide inhibitor. It inhibits its own metabolism or something like that. Okay. It is metabolized to alloxanthine that you already saw here. It is metabolized to alloxanthine. It inhibits its own metabolism. This is also interesting. It inhibits its own metabolism. So it will get, whatever gets converted to alloxanthine, it's fine. But whatever remains, that will get excreted unchanged because it will inhibit its own metabolism. Okay. So we are done with this slide of allopurinol. We have to continue. We will look at the interactions of allopurinol. Okay. Are you fine? Are you okay? What are we looking at today? Allopurinol. We are looking at allopurinol. We are looking at allopurinol today. Good. Wake up if you are sleeping. Now let us move on. Interactions of allopurinol. This is an anti-gout drug. Basically, what and all it will do? It will increase the, it will potentiate 6-mercaptopurine azothioprine. It will potentiate the other drugs. So it is giving more power to the other drugs. It also potentiates warfarin. It potentiates thiophylline. So it potentiates everybody. It potentiates all these people. Okay. Then this probenecid shortens the T half of alloxanthine. So probenecid, one second. See, everything it is potentiating here. Now allopurinol prolongs the T half of probenecid. Obviously this allopurinol is another sacrificing good person. It will potentiate all these drugs. It will prolong the T half of probenecid, obviously. So allopurinol is like, hey, you all work, I will sleep kind of a drug. Allopurinol will potentiate everybody else. Even probenecid, it will prolong the effect. But probenecid is not so good. It will come ulta and make alloxanthine be less. See, probenecid shortens the T half of alloxanthine. But allopurinol is this allopurinol. It's a very good person. It will potentiate everybody on earth. When you give this allopurinol with ampicillin, right? Skin rash can occur. Skin rash when allopurinol given with ampicillin. This we have to add even in the side effect. Okay. So in adverse effects, remember. So hypersensitivity is the main thing. Okay. Allopurinol, hypersensitivity. Allopurinol, hypersensitivity. This you should remember. Because allopurinol hypersensitivity is the only thing that you can write, okay? Others and all are very minor. Whenever hypersensitivity occurs in this patient, he took allopurinol, guys, okay? And now what happens? He has hypersensitivity reaction. In that guy, don't give allopurinol again. Don't ever start it also again, okay? Stop the allopurinol and don't give him, okay? The skin rash can occur with allopurinol when you're giving with ampicillin. Stevens-Johnson syndrome, that is again a skin condition, right, can occur with allopurinol. All these are hypersensitivity only, right? Look at this. This is Stevens-Johnson syndrome, some skin condition. Okay. So allopurinol, you should remember all this. Remaining you will write, because anyways it's given orally, you will write gastric irritation, nausea, liver damage, all that you will write standard. Headache, dizziness, headache anyways you will write for all the drugs, right? Headache, dizziness and all that. So, adverse effects of allopurinol, remember hypersensitivity. Main thing is hypersensitivity, Stevens-Johnson syndrome. Don't give allopurinol again. Stop it completely. Okay. Then what are the precautions and contraindications you should take when you should make note of when you are giving allopurinol? Precautions is whenever you are giving allopurinol, you should tell that person to take a lot of water, right? Even like probenecid, they should take a lot of water, even in allopurinol. Contraindicated in hypersensitivity patients, just now we told you allopurinol hypersensitivity, don't give again. Pregnancy and lactation, don't give. Standard things right off. Okay. What are the uses of allopurinol? Very quickly we'll look at the uses of allopurinol. Not at all difficult, guys, don't worry. See, it's the first choice in chronic gout. You already know this. Can be used in overproducers of uric acid and under excretors of uric acid. So people who make more uric acid, they also you can give. People who are not excreting uric acid enough, from there also you can give. In severe cases of tophi and nephropathy also you can give. In fact, this allopurinol can reverse these conditions in long term. Imagine, it can not only like control, it can reverse the tophi and nephropathy, right? Then it can be used along with uricose urics when body load of urate is large. That means you can combine it with probenecid acid if required. Not actually recommended only if it is like very high load of urate, I think. Okay. Who am I to recommend anything, guys? See what it is written. It's if when body load of urate is large, this allopurinol can be combined with this probenecid. Okay. Allopurinol can be given long term. Aren't we happy? So happy. Allopurinol is such a nice drug. Can be given long term. Even if the secondary hyperuricemia is there because of cancer, because of drugs like thiazides, furosemide. Even in such reasons, causes for hyperuricemia, you can give allopurinol. You can also give it prophylactically. So you are giving cancer therapy or you're giving thiazides and you think that this person can go into hyperuricemia. Then prophylactically also in prevention ways itself you can give off allopurinol. You can use it to increase the action of all these anti-cancer drugs. Obviously, this allopurinol is such a cute drug. It will increase the action of the other drugs. So to potentiate the other drugs, you can combine it with all these anti-cancer drugs. Okay. Then lastly, don't use an acute attack of gout that you already know. Don't you know this already? How many people don't know that you should not use these drugs in acute attack of gout? Everybody knows because we have watched all the videos. You have watched this video already, right? From the beginning. In the beginning, we already mentioned, right? In acute attack of gout, you should give only anti-inflammatory drugs. Where is that thing? Here, see? Acute gouty arthritis, you should not give these drugs. You should only give anti-inflammatory drugs. Okay. That's all, guys. We have covered allopurinol. Hope you are happy. Allopurinol is the first choice of drug for chronic gout. It is a synthesis inhibitor. It will inhibit the synthesis of uric acid. It is a hypoxanthine analog. It will inhibit xanthine oxidase. So, uric acid will be synthesized less. Hypoxanthine and xanthine will increase, but however, they will be excreted easily from the kidney. So, no problem. Everybody is happy. Doctor's happy, patient happy. Okay. We'll meet you in the next video, guys. Take a break, relax, enjoy. Bye-bye.